Dr. Yevoo, please come again.
I said we are having challenges with playing the song. So if you are here, come and add your magic touch. Can you hear me? Emmanuel? Hello, everyone who have joined us today. We are waiting for a couple more minutes for others to turn up. Have patience with us. We'll be with you very soon. Thank you for joining. Let's give everybody about 3 more minutes to join, then we can begin. Thank you for your patience. Welcome, everyone, and thank you for joining in today. I especially want to give thanks to the African Preeclampsia Network for putting and other partners for putting this webinar together. This is the second webinar in the third of a series in anticipation for the launch on the 21st of May. Which will be the milestone that we are all looking at. Today's encounter will be a very exciting one, and I want everybody to come along with me and enjoy the sessions. I'll be your host, your moderator for today. I'm excited to do that, but at the same time, very sad that I'm missing my co-moderator, my wonderful co-moderator, Dr. Garti. But despite that, I'm just promising you that we'll have a fun time. Sorry that you'll be stuck with me for the next 1 hour, but everything I hope will go on. Before we begin, we need to start some housekeeping notes. Please ensure all your microphones are muted. If you want to ask a question, please indicate in the chat, and I'll invite you to ask your questions. And then you kindly ask you to unmute when you are done. Please note this meeting will be recorded and made available through the APEC Ghana website and social media platforms. If you do not want your name or video to be there, kindly turn off your videos and then also use a pseudonym or your initials to be able to keep your anonymity. Next slide, please. Our speakers for today are Dr. Knipe and Professor Maswime. We'll go through a Q&A sessions, and then we'll have a closing exercise. Next. So, as an icebreaker, I want to know where you are joining from, whether the town, the region, or the country. And we like to connect with you, need to interact with you. I'm looking at the chats. Kindly tell us where you are coming from in the chat, and I'll kindly read it for you. So far, there's nobody there. I am connecting from Ghana, from the Netherlands. Thank you. From Ghana, Camilla from Ghana. Kingston from Jamaica. From Malawi, Alexander from Malawi. Thank you for connecting today. I promise that to be a fun and exciting, engaging into. From Nigeria. Okay, so could you share a fun moment from your region for everyone to know what is fun, a fun fact from your region and for your country? In Ghana, we make the best jollof, and then the Nigerians know that, whether they agree or disagree. Netherlands, what fun facts do you have to share? Yes, Camilla agrees that jollof in Ghana is the best. In Netherlands, a lot of cheese. Thank you for prompting me. Is the sound better now? Emmanuel from Ghana, thanks for connecting. You eat all the cheese in Netherlands. You have chambu fish. Jamaica, we have curry goat. Okay, so now I also want to know your profession, who we are engaging with. I'm a researcher. Gari cassava flakes, the lifesaver in Nigeria. What is your profession? Interesting to know. Who are we? Health economics. Thank you for connecting. Who else do we have here? Don't we have the researchers, the clinicians, social epidemiologists? Thank you for connecting. Okay. So, educator and a researcher, what are you hoping to learn today from this webinar? Ernest in Kenya, Rosalind Juma. What are you expecting to gain from this webinar? Any challenger? Who wants to go first? What are you hoping to learn today? Winfrey Boachi, midwife resident, welcome. What are you hoping to learn from today's webinar? Okay, you learn a lot, a great of information. You have a lot of information for today. Shall we go to the next slide, please? Okay, so the theme for today's webinar is bridging the preeclampsia in Africa, bridging the gap and access in care delivery. We hope that at the end of the day, we examine approaches for improving access to quality healthcare and effective management for preeclampsia, with our focus in strengthening health systems and improving care delivery. You know all the challenges that we go through as African women when we want to exercise our rights and go through the reproductive journey. You know the challenges that we all go through, and that is what we want to address in this second webinar. Next slide, please. Okay. We expect that at the end of the day, we have a strengthened multidisciplinary team would identify health systems gaps, and then we promote concept-specific solution, African solutions that would help everybody in the African continent, depending whether you are poor, rich or not, live in a remote area or not, should be able to solve that problem of eclampsia and preeclampsia to improve maternal mortality and prenatal mortality. The next slide, please. I'll be your moderator for today. I am Linda Lucy Yevoo in the Public Health Unit of the Ghana College of Physicians and Surgeons, and also a medical anthropologist. Today we have two speakers. We have Dr. Knipe and then Professor Salome Maswime. Our speakers, our distinguished speakers, Dr. Knipe will begin the discussions, followed by Professor Maswime, and it will promise to be an engaging, very insightful session. We start with Dr. Knipe. Dr. Knipe, ladies and gentlemen, is joining. It's a pleasure to introduce her. She's from a specialist gynecologist from the University of Wits, Stellenbosch, in Cape Town. She's currently pursuing a PhD and focusing on cerebral autoregulation in preeclampsia through an international collaboration between Stellenbosch University and the University of Gothenburg. Her work brings together clinical practice, academic medicine, and research with particular interest in preeclampsia, maternal mortality, and minimal invasive judgment. She is dedicated in advancing research, strengthening specialist training in resource limited setting and promoting evidence-based care across Africa. Please welcome Dr. Knipe. Dr. Knipe, your audience, Dr. Knipe. Thank you very much.
Good afternoon, good evening, and good morning, depending on which corner of the continent or world you are joining us from. Thank you, Linda, Dr. Yevoo, David, and the African Preeclampsia Network team for the privilege of this invitation and for the vision behind this maiden webinar series. To my fellow speaker and to everyone that's with us today, thank you for being here. Over the next 20 everybody can just mute their... Okay.
David, can you please unmute anybody whose microphone is on, please? Thank you.
Okay.
Yes, we're good to go.
Can you hear me?
We
Yeah,
can,
loud
but
and
it's
clear.
a little bit husky. Not too clear.
Okay. Now, can you hear me now? Okay.
Yes.
Let me share my screen. Can you see the slides?
Perfect.
Okay. So over the next 25 minutes or so, I would like to take you on a tour. Not the polished tour, the honest one. A tour of the system gaps that decide who survives preeclampsia in Africa and who doesn't. We will spend a little time on what is not working, but we'll spend more time on what already is and what could. So let's begin. I want to start where every honest conversation about preeclampsia in Africa has to
Dr.
start.
Knipe, your audio is still not too great.
Okay, can you hear me?
Yes, loud and clear.
Okay, let's see. Okay, can I continue?
Yes, we can.
Okay. I want to start where every host conversation about preeclampsia, honest conversation about preeclampsia has to start, with two women. The first lives in Oslo. She's 28, expecting her first child. Statistically, and I admit this is a cold view, she has, over her reproductive lifetime, a 1 in 7,900 chance of dying because of that pregnancy. To put it another way, she is more likely to be struck by lightning. The Norwegian state has, for the most part, lifted the threat of maternal death off her shoulders entirely. The second woman lives in Jamina in Chad. She's the same age, same hopes presumably for the child she's carrying, but her lifetime risk of dying in that pregnancy is 1 in 36. Take a moment with that number. That is a 220-fold gap between those two women. 220. And here's the part that should be keeping us up at night. Preeclampsia, the disease we are here to talk about, is biologically the same condition in both women. Same placental dysfunction, same endothelial cascade, the same eventual seizures if untreated. The difference between life and death is not biology. It is the system each woman happens to have been born into, which means, and this is the only useful conclusion, every one of those deaths, in principle, is a system we can fix. So let's talk about the size of that fixable problem. Three numbers. 70% of all maternal deaths in the world happen in sub-Saharan Africa. In 2023, that was about 182,000 women, daughters, sisters, mothers, most of them under 35. Sub-Saharan Africa carries 70% of the maternal mortality burden, while contributing about 14% of global births. That is the arithmetic of inequity in a single ratio. The second number, preeclampsia. The pooled incidence in sub-Saharan Africa sits around 13%. That is almost double what we see in high-income countries. So this is not just a death rate problem. It is a higher incidence problem layered on top of weaker systems. African women biologically develop more of this disease. The third number, of those African maternal deaths, around 16% are attributable to hypertensive diseases of pregnancy, preeclampsia and its complications. Do the maths, and what you get is this. Roughly one African woman dies of preeclampsia and its complications every 10 minutes. Every 10 minutes. In the time we will spend on this webinar today, 9 African women will die from a disease we know how to manage. I don't say this to be dramatic. I say it because the scale of preventability is the lever we are standing on. None of these deaths is a mystery. All of them are the failure of a system. For 30 years, the way we have framed this problem in global maternal health has been the 3 delays model. Thaddeus and Main, 1994. If you've ever sat in a maternal health workshop, you have heard of it. Delay number 1, the woman deciding to seek care. Delay number 2, reaching the facility. And delay number 3, adequate care once she's there. It was a brilliant framework. It told the world that maternal death was not a medical event happening at the moment. It was a journey with multiple bottlenecks. And honestly, it underwrote most of the gains we have made. But the world has shifted. Most African countries today, in most African countries today, there's about more than 80% of antenatal care coverage. In some of our settings, 90 up to 95. So most women are reaching the facility. Why are they still dying? The honest answer is that delays 4 and 5, quality of care once you get inside of the building, and continuity of care across the puparium are now where the bodies are piling up. A woman who is admitted, stabilized, and then handed over 3 times across 3 shifts and then discharged at 48 hours postpartum without follow-up. She may have crossed every gate in the original 3 delay model and still die. So for the rest of this talk, I would like us to hold all 5 in mind. The first 3 delays got us this far. The next 2 are what is stopping us. So I want to go through a few pillars. Pillar 1, geography. Where you live still decides whether you live. There's a famous paper, again by Thaddeus and Main. It's not new, but it's still painfully accurate, called Too Far to Walk. That is the title. It captures something that data continues to bear out across the continent. In many of our settings, the nearest emergency obstetric facility is more than 2 hours away on foot or by local transport. In fulminant preeclampsia, 2 hours is the difference between a controlled blood pressure and an intracerebral hemorrhage. The second piece of the geographic story is concentration. ICU beds, reliable magnesium sulfate, specialist obstetricians. These resources cluster in capitals. Lagos, Nairobi, Johannesburg, Johannesburg, Addis, which means a woman in a rural district does not just live further from care, she lives further from competent care. And the gap between those things is enormous. The third piece is the time of day collapse. Eclampsia does not politely wait for clinical hours. Ambulances after hours are rationed. Private transport requires cash upfront. I have personally watched women arrive at 3 in the morning whose clinical course had already been written by what happened or what did not happen the day before. Look at the panel on the right-hand side of the slide. 438 maternal deaths per 100,000 at one of the busiest tertiary referral centers in sub-Saharan Africa. Despite 95% antenatal care attendance, women are reaching us. The bottleneck has moved. Coverage of contact is no longer the issue. Quality on arrival is. Pillar 2, socioeconomics, inequity that survives the ambulance ride. Even when a woman reaches the facility, who she is shapes what she gets. There are 4 threads here. The first is health literacy. Up to 77% of women in African studies who develop preeclampsia report no prior knowledge of the condition. They don't know that a headache plus visual disturbances plus a swollen face is a flag. They do not know that protein in your urine matters. We cannot ask women to seek timely care for a condition they have never been told to be afraid of. The second is adolescent vulnerability. Teenage primigravida carry the highest hypertensive disorder of pregnancy risk of any age group. In South Africa, saving mother's daughter, 38% of teenage eclampsia deaths occurred postpartum, when she is already at home, often without anyone watching her. The window where we lose her is after we have discharged her. Third, and this is one we don't talk about enough, is the catastrophic out-of-pocket costs. Even when consultations are free, transport is not, drugs are not, lab tests are not always. Families take loans to get a woman to hospital and then cannot afford to follow up that visit. That might catch the postnatal seizure before it kills her. The fourth is decision-making power. In many of our communities, the choice to seek care, to consent to transfer, or even to disclose a pregnancy, those decisions don't sit with our patients. They sit with the partners, with the mother-in-laws, with the traditional leaders. So our system can't just be designed around her. It has to be designed around the people around her. Pillar 3, the diagnostic delay. And this is one, in some ways, the most maddening, because preeclampsia is a disease we are meant to be able to diagnose with a stethoscope, a blood pressure cuff, and a urine dipstick. 4 points here. Number 1, unreliable blood pressure measurements. I'm not talking about exotic problems. I'm talking about cuffs of unknown calibration, cuffs that are the wrong size, or cuffs that have simply gone missing. A single misreading reclassifies a sick woman as a well woman and sends her home. Second, proteinuria. Dipsticks run out. Spot urine protein creatinine ratios are rarely available at primary level. So diagnosis defaults to clinical impression, which means it defaults to whoever has the most experience in the room, which on a Saturday night might be a community service doctor 6 months out of internship. Number 3, and this is specifically African, it mimics in endemic disease settings: headache, jaundice, abdominal pain, blurred vision, feeling unwell, nausea. That is severe preeclampsia, but it's also sepsis, malaria. Without a reliable blood pressure reading, they can look identical. we've all seen and treated women for 48 hours before realizing the blood pressures were high. And number 4, atypical presentations. Postpartum eclampsia, the normal tensive health, the silent early severe disease that arrives at 26 weeks before we even started screening for it. Our antenatal protocols are designed for the typical case. The atypical case, which is a substantial minority, still fall through. The net effect of all 4 in too many African settings. Severe preeclampsia is diagnosed by its complications and not by its precursors. Pillar 4, referral. And this is the slide I want you to remember if you don't remember anything else about this talk. This data is from a mixed method study in Ethiopia. 261 women referred up the system with severe preeclampsia. So these are not borderline cases. These are women who the referring facility had already identified as critically ill and was actively transferring the patients to a higher level of care. Of those women, only 17%, about 1 in 6, received the loading dose of magnesium sulfate before transfer. Only 14%, about 1 in 7, received any antihypertensive therapy. And only 38% arrived with stable vital signs at the receiving unit. A stunning 9% had received the full recommended pre-referral package. Let me put this another way. 91% of critically ill women traveled sometimes for hours without the basic interventions we know prevent eclamptic seizures and stroke. They arrived at our doors destabilized, which made the receiving unit responsible for both the initial management and the definitive care in a single resuscitation, often in the back of an ambulance bay. Now, this is the important part. The protocol for pre-referral care is not unknown. It is not contested. It's not expensive. The package is on every African national guideline. The bottleneck is supply, training, and confidence at the referral facility. The lesson buries itself. Strengthening the first hour of care at the referring clinic saves more lives than any tertiary upgrade. We are spending on the wrong end of the journey. Pillar 5, workforce. The people inside the system. 3 numbers, then 4 drivers. 1 midwife to 50 plus laboring patients is a routinely reported ratio in a busy sub-Saharan Africa tertiary unit. Try to imagine 1 set of eyes and hands across 50 fluctuating clinical pictures, several of whom are preeclamptic. That is not healthcare. That is triage in a war zone. Less than 1 specialist obstetrician per 100,000 population. That is the reality in many African countries. The WHO recommends a much higher density. We are operating in many districts with no specialists at all. And in South Africa, a country with strong protocols and a central drug supply, 70% of hypertensive deaths are flagged with at least 1 avoidable factor. So this is not only a workforce shortage story. It is also a workforce support story. What is driving the gap? 4 threats. Skills, the brain drain of specialists to the private sector or leaving the country. Training bottlenecks, we have far more candidates than accredited posts. and uneven supervisor capacity, even in the posts that we do have. Burnout and model injury,
Dr.
repeatedly
Knipe, in 5 minutes, you should be concluding. Thank you.
Okay. Wait, let's move on. Pillar 6, infrastructure. When the basics are missing, guidelines do not save lives. 4 basics, 4 unglamorous, unheadline-grabbing basics. Functional blood pressure devices. Many of our primary level clinics either don't have working blood pressure cuffs, or they don't have them at all, or they're not calibrated, or the battery is dead from 8 months ago, or was never replaced. You can't diagnose hypertensive disease of pregnancy without a blood pressure cuff. Full stop. Magnesium sulfate is the cheapest, most evidence-based, most life-saving drug in our arsenal. It is on every essential drug list in the African country I have checked, and yet stock is often out, especially on weekends, especially after hours, especially in remote facilities. A drug being on the list doesn't mean a drug being in the cupboard. Hypertensive diseases, high care units, high care delivery units, ICU units. When a woman has eclampsia complicated by pulmonary edema or stroke, renal failure, that is tertiary, that is territory of critical care. Most African women with severe complications don't have access to. And at lab capacity, liver enzymes, platelet counts, quantitative protein, many of our facilities will send off those tests to a different lab and maybe get the results 12 to 24 hours later, well after a clinical decision had to be made on intuition. The metric we should be auditing is not, does this facility have it? It is it reliably, predictably, 24/7 available? Commodity reliability, not commodity existence. Pillar 7, data surveillance. We can't fix what we can't see. Robust preeclampsia surveillance is the precondition for accountability. And Africa is, in most countries, operating without it. 4 main problems. Firstly, we only have hospital data in the published literature. We mostly know about the woman who died inside of facilities, but what about the women who died at home before they could reach care or after we discharged them? They never enter our data sets. In Malawi mortality survey, more than a third of women dying from maternal causes never reached or could not return to the health facility. Our published numbers are just the tip of an iceberg. Second is the cause of death misclassification. Verbal autopsies, or used where there's no facility record. It often conflates eclampsia and epilepsy or sepsis and the catch of all sudden death. So our core specific data is sparse. And third, there's no preeclampsia registries. Most African countries have no longitudinal preeclampsia registry tracking incidence, severity, biomarkers, long-term outcomes. We are flying blind on a disease's natural history in our own populations. And lastly, the underuse of audit, where confidential maternal death inquiries do exist, like South Africa, Malawi, Uganda. The findings are really close the loop into protocol change at facility level. We diagnose the system failures and then we file a report. So you ask, what is the magnitude of preeclampsia in your country? The most honest answer in many African settings is we have an estimate, but we don't really have a number. Now let me hold up a mirror because I owe you my own context. South Africa is, by African standards, an upper middle income country. We have national protocols, we have a central drug supply, we have confidential inquiry into maternal deaths that's been running for over 25 years. And we still cannot close the hypertensive disease in pregnancy mortality gap. It's still amongst the commonest direct causes of maternal deaths contributing 14 to 19% of maternal deaths across the recent triennia. About 70% of those deaths are flagged with one or more avoidable factor. Cerebral complications, intracerebral hemorrhage in particular, remains the single largest pathological endpoint. And magnesium sulfate, as I said, is widely available. Guidelines exist and training happens. So why are we still here? Because drug availability is necessary but not sufficient. That is the lesson I want my colleagues across the continent to take from us. If you are looking at South Africa and thinking, when our drug supply matches theirs, our deaths will stop, they will not. The gap does not close on commodities alone. It closes when people, pathways, audit systems, and the equity of access are all moving together. To put it simply, the work is in the system, always in the system. So I can't just leave you with a burden. Then I failed at this talk. So here's the truth. The most important advances in preeclampsia care of the last decade have not come from Boston or Berlin. They have come from low-resource trials. They have come from Africa. The cradle vital sign alert, a robust semi-automated blood pressure device with a traffic alert, light alert, designed for primary level midwives, validated in stepped wedge trials across sub-Saharan Africa, India, and Haiti. It survives the heat and dust, and it doesn't need calibration engineers. Our point of care PLGF, like the Papagayo trial that we're busy running now, whole blood placental growth factor point of care testing that's been demonstrated in Sierra Leone, not Sweden, to accurately rule out maternal death, eclampsia, and stillbirth in women with suspected preeclampsia. It's a finger prick test and 20 minutes that lets a clinician in a district hospital decide who needs urgent transfer and who can be safely watched. Our access to advanced technology and remote reviews, SMSs, and WhatsApp-based decisions support, image-based dipstick reads, telementoring of students and teams. We are bridging specialist scarcity in real time with phones that everybody has, task-shared protocols. These tools work and is the key. They only work when surrounded by training, audit, and reliable supply chains. The frontier is no longer basic intervention. It's implementation science. And it's making things that already work everywhere. So what is bridging the gap actually look like for the next decade? 5 priorities. I will be brief on them. Number 1, make the basics non-negotiable. A functional blood pressure device, magnesium sulfate, and proteinuria testing in every facility that books a pregnancy with real-time stock reporting. If that data is collected nowhere else, this is where it should be collected. Number 2, empower the first responders, the midwives, the primary care nurses, the first hands on every preeclamptic woman. Standardize pre-referral packages and run by them. Number 3, build referral arteries, not just referral points. A referral is not a piece of paper. It's a pre-arranged transport. It's a phone call before the woman moves. It's a warm handover that begins at the sending facility and ends with named receiving clinicians. Ethiopian data that I showed you does not change without this. Number 4, invest in surveillance infrastructure. A feedback loop that closes into protocol revision. An audit without action is just paperwork. Number 5, place the woman at the center. Pre-eclampsia literacy embedded in your antenatal contact, in the schools, in the community media, with the male partners, the mother-in-laws, the traditional healers. Engage them as partners of the work, not obstacles to it. None of these require new science. They just require collaboration, which is gratifyingly what the Africa Preeclampsia Network exists to build. So in closing, I want to land on a single idea because I think it's the only one that actually changes the game. Equity is not a side effect of better care. It is the strategy. What I mean by this is we can't keep treating the gap between Lagos and Stockholm or between Johannesburg and Limpopo village as a regrettable secondary outcome of doing the best we could with what we have. That framing protects us. It lets us go home at night feeling that we did everything we could. But every woman who develops preeclampsia in Africa, wherever she is, deserves the same chance of surviving as a woman who develops it in Stockholm. Not approximately the same chance, the very same chance. That's not an aspiration. That is not poetic. That is the design specification of the system we are now obliged to build. And the moment we accept that, what we measure, what we prioritize, and what we audit, and where we put our money will change. So nothing I've said matters unless someone in this webinar does something different on Monday morning. So let me address you, the clinicians in this webinar specifically, the midwives. Pull up your last 10 preeclampsia admissions when you log off today. Where in the chain did time leak? Was it at the triage? Was it at the lab? Was it at a handover? Find the leak. Bring back those minutes. You don't need permission to do that work. To the researchers, co-design with the woman that you are studying and publish in journals that your colleagues can read at district level. We can't keep producing knowledge that stays in private subscription paywalls in the global north. And to the public stakeholders, treat magnesium sulfate stock shortages as a sentinel event. A facility that cannot rely on this stock should not, in my view, be permitted to book pregnancies unless that is, or until that is resolved.
Thank you, Dr. Knipe. I told you we have an exciting time. This is just the tip of the iceberg. Dr. Knipe, don't leave us yet. We'll be waiting for the Q&A sessions. So kindly wait after Professor Maswime's presentation, then we take the Q&A together. Please express your emotions with a clap, with a virtual clap, virtual thumbs up, anything that we need to use to boost her morale. Thank you so much for a fantastic presentation. Our second speaker is Professor Salome Maswime. Today is the Women's Day. Monday it was the Men's Day. Today we are leading the challenge. As women, we need to be the ones who are advocating for women. Thank you so much. Can we have Professor Maswime's slide, or she'll be sharing it by herself? Okay, now it is a great pleasure to introduce the second speaker, Professor Salome Maswime, a distinguished South African obstetrician, gynecologist, clinician, and global health leader. Professor Maswime currently heads the Global Surgery Division at the University of Cape Town, serves as a director of UCT WHO Collaborative Center on Integrated Clinical Care, and has recently been appointed as the incoming head of the School of Clinical Medicine at Wits University in South Africa. She has played an influential role in shaping healthcare policy, regulations, and surgical care across South Africa and the South African development community. And she's widely recognized as a pioneer of global surgery education in Africa. In recognition of her outstanding contribution to science and healthcare, Professor Maswime has received numerous prestigious honors, including the award from the President of South Africa, the National Science and Technology Forum, and the South African Medical Research Council, and Zenith Global Health UK. Let's welcome Professor Maswime. The floor is yours.
Thank you so much. Very delighted to join you tonight, and I hope you can hear me and you can see my slides clearly?
You can see it
All right.
clearly, and your voice is clear.
All right, thank you so much. So as I was saying, quite really delighted to join tonight. And I think, there'll be a number of overlaps in the talks that have, with my talk and the previous talk. But yeah, you'll see as we go, I've also tried to pitch it from a perspective of global surgery, global health. So as we go, hoping you will enjoy the approach that I have for the talk. Okay, so I'll start off, and I think some of this. So I will skip some of the things that have already been touched on. We all know, preeclampsia is a common disease, part of hypertensive disorders of pregnancy, leads to preventable maternal and perinatal mortality and morbidity globally. And the main thing is that there are huge disparities in the prevalence of the disease and also in the outcomes of the disease. And so in areas where there are high population risks and with low health system capacity, women do not do well with preeclampsia, and we end up having with a lot of preventable deaths, and particularly in Africa and in low and middle income countries, limited access to high quality antenatal care, delayed diagnosis, and increased risk of severe complications caused by the delays that have been mentioned already leads to poor outcomes. And so it's really not just looking at the disease, but understanding the system which led to the disease. And this is an example of, bringing the disease to life. And often we, as clinicians, we look at the patient that's in front of us and can often work out what was the cause of death, what happened, and what could have been prevented. But we don't often look at what were the health systems factors and how do we treat sick health systems, because that's essentially what today is about. It's not how do we treat the disease itself, but how do we treat sick health systems that are not able to cater for and to manage the disease appropriately. So this is just an example of a 29-year-old woman who is unbooked. So she arrives at a district hospital. She's 36 weeks pregnant. She's got a severe headache. Her blood pressure is elevated. A diagnosis of preeclampsia is made, but the woman, while she's in hospital, then collapses in the ward. And of course, treatment, she started on treatment. A decision is made for her to have a cesarean section. But this is a district hospital. There are concerns about whether to do the cesarean section there or to transfer her to the next level of care, especially since she's collapsed. And you can't blame the doctors who are looking after her for being afraid of caring for her, because they also understand their own resource limitations and are concerned that what if she really dies in their hands when she could have been sent to another hospital quickly enough. But, due to constraints, as we know them in health systems barriers, the ambulance arrives 8 hours later. The patient eventually, when she arrives at the referral hospital, she's got decreased fetal movements, and the patient arrives, has a seizure again, and dies and loses her life. And this is the reality of African women and what happens in many district hospitals, where people are faced with the choice of whose life to save and whose life to prioritize. And even when they've made the choice that let her get better care and go to a facility that can offer better care, but the health system, the referral system, the ambulance system often fails them as well. And if you look at why did Miss X actually die, she was unbooked. There was a delay in seeking care. There was a delay in reaching the healthcare facility there were delays in receiving appropriate care, and once the right diagnosis had been made, there were delays in her reaching the referral hospital. But then there are also issues of negligence and workforce shortages and resource limitations, and why could she not have radiological tests? Why could she not get her blood results on time? Could she not have been put in some sort of high care setting where she was getting better care? And so this is really just emphasizing that we're not talking about a clinical problem here. It's really a health systems problem. And the reason why patients like this die is it's a combination of factors which may have to do with the patient, the health system, the care given within the facility. But sometimes you also face issues of just negligence and poor resources and poor workforce issues, and often when we try and address what the problems would have been, we don't put enough emphasis on issues such as negligence or issues such as workforce shortages, and we try just enforcing how the clinician could have done a better job and how preventable the death would have been. And of course, you could do a post-mortem and you'll find a clinical cause of death and you can work out what happened from a clinical perspective. But this is not, as the previous speaker said, a biological discussion. And at the end of the day, the system that is sick is really what needs to be addressed and treated. And then the concept of capacity to rescue. So we've got the concept of failure to rescue is really the idea and the understanding that not every complication in medical care is preventable. So we are not trying to say that the diseases and the complications themselves are preventable or will always be preventable, but we are saying that a health system should be able to rapidly identify and provide treatment and manage the conditions and the complications as they occur. So Ms. X is a classic a case of failure to rescue, that the health system could not cater and support her as she experienced complications for the disease that she has. And capacity to rescue is this idea that you can improve the health system through interventions that are going to strengthen it. And much of my talk is going to speak about improving health systems. And I thought, just to steal from some of the global surgery work, we use this global surgery framework, which looks at health services and this intersection between services, health systems, and governance, and issues around policy, for example. And so this is where, when you're looking at improving care for a population, this is what we look at. You want to strengthen the service, strengthen the system, and improve the governance and policy factors. But improving health systems, we're using the term improving more and more rather than strengthening. And for me, it's this concept of improvement science, which really looks at literally improving the health system and finding strategies that are going to improve the healthcare that is provided. And also, this is understanding how a health system is defined, looking at the WHO building blocks, that in clinical medicine, whilst the focus is often around service delivery, but when you look at health system strengthening, you have to look at human resources, medicines and technologies, financing, information systems, leadership and governance. And those are really the things that will determine how which interventions you are required to improve your health system. So what we're really looking at from a preeclampsia perspective today is, how do you address the gap between the health services and systems? Because we are clear that the real problem here is this gap and this break in the system. But we also understand that every patient is different, and they come from different social groups, have different economic conditions. We also understand that we've got different political and geographic determinants of health, which will determine what resources, what healthcare, what facilities one has in a certain area, and how healthcare is prioritized. And then, of course, the biological, which is really in the clinical realm. But it's important always to remember that healthcare is political, and it's not just about the clinical side of things, but it's the political decisions that are made and political priorities on where the emphasis is going to be. Today, we're talking about preeclampsia, but tomorrow we could be talking about hemorrhage. The next day, we could be talking about sepsis. And these are conditions that really carry a high morbidity and mortality when it comes to maternal health. But maternal health is also competing with other diseases as well, child health, infectious diseases, mental health. And so at the end of the day, the distribution of resources is not purely from which disease affects people the most. It's about the political decisions and will to ensure that resources are provided for certain conditions. Also, what are the drivers of poor women's outcomes? It's their status in society, the status of the healthcare that they would receive in a certain place, and the state of the health system. And so you have to look at these things all together to understand why women die from preventable deaths. And that at the end of the day, it's really an equity issue. It's a choice of whose life is worth saving. Societies make that decision when they decide that they're not going to prioritize maternal health, or that they are not going to invest in diseases like preeclampsia. And we really need to question how important are these diseases and women, and how important women are considered in the societies that we live in. So if you look at preeclampsia from a public health perspective, we know that it remains an important public health threat, and it contributes to preventable mortality globally. And the issues are with the prediction, prevention, the diagnosis and management, and the lack of being able to address it at these 4 levels. But we also know that functional health systems are required to address the challenges that are associated with prevention, detection, and management of preeclampsia. So instead of just thinking about which drugs do we need to treat the disease, you need to think about how can we strengthen and improve the health system in order to address the challenges. When it comes to prediction and screening, and you need to think about this from a low and middle income perspective, that with the screening modalities that are provided, how reliable are they, and so we are recommending more and more the use of biomarkers, for example. How affordable are these? How accessible are these to women in communities with the highest burden of disease, which also happen to be the poorest communities in the world? If we're going to use Dopplers, we are struggling as it is just to give women one ultrasound. In many public sectors, there isn't access to ultrasound. And so many women will be missed for many obstetric conditions just because we are not able to provide the services. So much as the literature can emphasize what screening modalities are recommended, you need to remember that often these are not accessible. For many of us, it's the being able to do the blood pressure and the urine, and checking the urine, and that's and then the symptoms. And by the time you have those symptoms, it's often also quite advanced. I won't go much into the 3 delays because this has already been addressed by the previous speaker, but just to to emphasize that the delays in seeking care also at times have to do with the perceived poor quality of care that patients associate with some of our health facilities. And so it's how acceptable are our health facilities to the communities that we treat as well. The delay in reaching the health facility, as mentioned, the location, the distance, the lack of transport, the reality that facilities are often in urban areas. And even though we have even though for most places in the world, you may have reached a health facility within a 2-hour radius, but you are not going to find specialists in many of those facilities. You may not even find a doctor at the time that you need to be referred to a higher level of care. When it comes to the delays in health service provision, the attitudes of health service providers is also included as a risk factor. And then we know about the cost of the equipment, the medicines is important. And it was also mentioned in one of the papers I read that often, drugs like magnesium sulfate, etc., are often limited to teaching hospitals. And so often, whilst in teaching hospitals, you may give various drugs and they're accessible, but outside in the district hospitals, patients are not able to get some of the drugs that are recommended in the guidelines. Then one must always remember policy issues, that the deficiency in policies and guidelines, the poor data systems, poor routine data systems, poor record keeping, even when we do have the files, often not well kept and too summarized, and one cannot follow well. But then also at the end of the day, policy isn't always evidence-based. And so we need to remember that prioritization of conditions is often achieved through advocacy, and we don't always have good advocacy groups, especially around diseases such as hypertension. So what are the clinical strategies for an LMIC? And of course, we'll know early booking, time deliveries, offering postpartum care, and then having essential drug lists. Where does magnesium sulfate sit? Is it on the essential drug list for the country or not? Access to ultrasound, access to the drugs that I mentioned, and the prevention and all of that. So we need to think about that, but also ensuring that there's a continuum of care and ensuring that women recover and that we don't forget about them after they've delivered. But if you look at what are the public health strategies, and this is particularly for this talk, increased focus on quality of care, ensuring political commitment and resources are provided, improving emergency obstetric services, ensuring availability of trained personnel, drugs, equipment at every level, case management protocols, monitoring standards of practice. And so it's important to think about it at population level and not just at individual patient level. But we have to come up with ways and interventions of improving services and systems. And again, I'm going to speak also from the work that we do in global surgery to give examples. So from a public health perspective, and this is literature and examples that are there in literature of interventions that have been implemented, innovations to improve the public health interventions for preeclampsia, such as community engagement and health education programs and campaigns, community screening programs, using community healthcare workers to do clinical assessments and mobile assessments, task shifting, task sharing, using mobile applications, especially for the monitoring of the blood pressure, unique transportation models so that patients can get to health facilities when they need to. reorganization of care models, changing the way so that there aren't delays within the systems. These are also quality improvement interventions, and then capacity building. And these are various workshops that may be run for nurses, for doctors to improve their management and their skills in terms of treatment. Then I want to touch on obstetric transition, that it's important that you also think of the obstetric transition model, which really what it proposes is that when one looks at maternal mortality rates, there are interventions to strengthen the health system or to address the challenge needs to be based on the actual challenges faced by that society and address those barriers. And in the same way, if hypertension and preeclampsia contribute significantly to your maternal mortality rate, one could use the obstetric transition model also to make informed decisions on the strategies that are required, from community engagement to quality improvement to infrastructure, etc., and looking at innovative ways. So it has to be data-driven, it needs to be evidence-based, and interventions need to be specific to the context that one is trying to address. In global surgery, we look at 4 particular areas for intervention. It's community engagement, capacity building, quality improvement, and policy engagement. And you could apply this for a population which has a high burden of preeclampsia. If your issues are at facility level, then you need to focus on quality improvement measures. If your issues are with the workforce and negligence, then you need to think about capacity building. But if you've got a population that is unbooked, arriving late, delays in seeking care, it's at community engagement interventions that you need. And obviously you need policies that align with the visions and the goals of the programs that you want to implement. So in conclusion, what we are looking at from a preeclampsia perspective today is using the improvement science model and looking at bridging this gap between services and systems. And of course, those of you who are familiar with my global surgery talks, this is also the same model which we use for global surgery to improve access to surgical systems and services, but it's all derived from this improvement science model, which I think is a useful model to look at from a health systems strengthening perspective in the context of preeclampsia. So thank you once again for inviting me today, and I hope the talk has been useful.
I must say the 2 speakers are wonderful. You've done a perfect job. I blow you kisses. And with everybody, send them a virtual hug, virtual clap, a thumbs up. You've done so well. I told you have an amazing time today. Now the floor is open for questions and answers. You are already having people who already want to connect with the 2 women, the speakers. And I'm so grateful and so excited that all is going on well. Professor Maswime and Dr. Knipe. Right now, we do not have any questions. They only want to connect with you. So the floor is open for questions and answers. Or they are too amazing, you have nothing to say, nothing to ask. Okay, Jacqueline, come on. Yeah, it's Jacqueline, the floor is yours. Jacqueline, kindly unmute and ask your question. Is Jacqueline Kello listening? Looks like Jacqueline cannot hear me. You cannot unmute. Let's see how we can.
Finally, I've good evening. I was failing to unmute. This is Jacqueline from Uganda, Makerere University. So looking at this year's theme of predict, prevent, and prevail as the international theme, and that's what we are running with to do awareness in our country. There's been a lot of talk on use of biomarkers for prediction. And given our setting where we are not even able to just take blood pressures in antenatal care, we still don't have BP machines in some of our lower health facilities. What is your take on uptake of biomarkers for prediction and even diagnosis, considering even the low-hanging fruits are still not in use? Thank you.
So who is the question for? Any of them can answer.
Any of them really, because yeah.
Okay. No, it's just two speakers. Prof, Doctor, anyone can attempt to answer. Thank you.
Okay, I'll start. So it's two things, right? That we want, our communities to have access to high quality care, despite the barriers and the systemic barriers that they may have. But we also want them to have, access to advances in science. And so there is something wrong if we say women in high income countries, let them have biomarkers, but women in LMICs must not have access to biomarkers because we just cannot afford it. And those are the systemic disparities that one needs to look at and address and really try to think about what are we trying to achieve here. So it would be wrong for me to say that, let's drop these biomarkers for poorer countries and poorer communities. We know in reality that, it's not always going to be possible. And we are really, in communities where we are struggling just to ensure that oxygen is available, issues of electricity and whatnot, you may not be able to provide the most advanced, not just in terms of medicines and imaging and tests, but we also need to strive where possible to make these accessible. And so also when we talk about SOPs and guidelines, we need to revise and remodel our guidelines that they are equitable. And this idea of best practice is based on how rich a country is, and therefore let's add other, all of these additional things because women can afford. We need guidelines that are balanced and also speak to the socioeconomic conditions of where people come from without compromising the care that can and should be offered. But let me pause there. I think Dr. Knipe will continue.
Thank you, Prof. Maswime. Now, just my 2 cents with regards to the using of the biomarkers. I don't think we're at the point where it will replace our simple measures, if that's what you were asking, in the places that don't have the blood pressure cuffs and things like that. But it does help us with certain other pitfalls that I have mentioned, like the fact that even where I work, we don't have beds, we don't have the capacity to do the 24-hour blood pressure monitoring for the patient to admit them. So in those settings, for us specifically, luckily we are one of the research sites for the point of care PLGF, and we have seen, it's definitely decreased. It decreases it guides your hospital admission because it will help you avoid the unnecessary admissions. Those ones that don't actually need, like I said, the ones that can go home, to differentiate between the ones that we're sending home and are dying at home, or the ones that actually are safe to go home without unnecessary hospital admission and all the costs that come with that. I definitely think that the point of care biomarker tests are cheaper than that entire hospital stay. So long term is definitely a cost saving option, and that's why we are all part of the big studies. And I mean, we know about Pelican, Parrot, Inspire, that's already looked at the Papagayo, that's busy running at the moment, looking at the feasibility of all of these tests. Specifically, I think Papagayo is in South Africa, Zambia, Sierra Leone, India, and Brazil. So similar type of socioeconomic situations, but funded by the people that have money, by King's College. So we'll see. And all of that's what we're here for, to find out what's going to work and what's actually going to be the way forward.
Thank you, Dr. Knipe. David Obadin wants to ask a question. It's over to you, David.
Hi, thank you both speakers for your wonderful presentations. It's really much appreciated. And to maybe put a bit of another topic that South Africa has been recently known for is for some xenophobic views from multiple forces inside of South Africa's country. And I was just wondering, because for us, the APN network, we're trying to set up a Pan-African approach to, for example, the preeclampsia care. And how do you guys feel that, given the fact that I believe 50% of the national resources going into the public health domain, reaching 85% of the people depending on the public health domain, how is currently the sentiment for healthcare workers, but also just people living in South Africa, for a lot of the migrants coming from Zimbabwe, coming from different corners of Africa, trying to reach healthcare that, for example, pregnant mothers need in relation to their PE check-ins. So that's the main question that I want to ask, is how currently is South Africa handling the approach for migrant mothers reaching the clinics in Cape Town, in Johannesburg. Thank you.
David, who do you want to address your question?
Yeah, so the main question is how do you guys...
who among the two speakers do you want to answer your question?
Maybe Dr. Knipe can please start.
Hi, sorry, I couldn't unmute myself. Sorry, David, could you just summarize the question
Sure.
again?
Let me summarize the question again. So currently in South Africa, a lot of the free healthcare has been going to also people coming outside of the South African corners. So people from Zimbabwe, for example, are also reaching the clinics. How do you guys currently feel that, for example, migrant mothers in South Africa are being helped with their preeclampsia care?
I definitely think that it's challenging. I mean, everything is more challenging when you're in a foreign setting, when you don't know the language, and like we said, when it's a different cultural background, and specifically among South African women, we know for a fact they may appear similar, but they are very, very different culturally, and they're not always accepted by our people. And especially because of the fact that we don't have enough beds for South African women. So, I mean, we see how they are basically bullied, and not unfairly so, because the South African women are also struggling, and they feel that how can somebody else get on top of them? So I mean, it's a scarcity problem. It's a scarcity issue everywhere. So it's, I mean, with the numbers, like you said, I mean, we've got all the stats, we've got the numbers, we're reporting the numbers, we know what we're dealing with, but how are we going to change it? And then, even though our numbers are terrible, it's still better than where these women are coming from. So even though they're getting treated really badly, they're still getting treated. It's better than nothing. So I've noticed, I mean, I've spoken to some of these women personally, and I mean, that's what they say. They say they will put up with it because at least they're getting care. They're getting to the quality care that I mentioned about.
Perfect. Thank you.
Yeah, and let me add from a different perspective and from a global health perspective. you need to look at the patterns around accessing care and acceptability of care and the length to which people are going to move around to access care, when they cannot find it. And so on one hand, you may have a health system which feels overburdened, but it's the same health system which has got a higher concentration of obstetricians and gynecologists and tertiary facilities that are able to accommodate higher numbers of people. And with globalization, when people cross borders to access care and to look for specialists and to look for surgeries, etc., who do you blame, the people or the health system? And if countries are not regulating, how this is done and the exchanges and the partnerships and the bilateral, approvals and all of that are required, you need to look at both sides, And so what we stand against is violence against patients, and disrespect to patients because of where they come from. But there is a need to interrogate how we strengthen health services across the region so that there is more equitable access to care across the different countries. Thanks.
Okay, so there's a question in the chat, and it's from Jacqueline again, Akelu. She wants to know the local name for preeclampsia in the different contexts. So maybe because you're coming from South Africa, how do you call preeclampsia in the local language? Because she finds it difficult to try to explain the condition to women.
I'm not aware of the name. I don't know, Prof.
No, I don't know any fancy name, but I mean, most people will understand hypertension and hypertension in pregnancy and high blood pressure in pregnancy. And I think that's a starting point. But as in translations and all of that, I am not too familiar. Thanks.
But I
So
mean,
there's no local name then.
Part of the point is the fact that it's so difficult to explain this. It's not part of your discussions at home. It's not a around the dinner table conversation. Hypertension is, diabetes is, those are common names that people hear floating around. Preeclampsia is not. So, like Prof said, everybody knows high blood pressure. But what about when the high blood pressure is not just high blood pressure anymore? As part of my research, I've got a pamphlet with pictures and explanations to try and explain to the patients. And then the next day, they still don't understand. And then it's in their language with images. It's a difficult situation. It has to be continuously reinforced. It's not a once-off discussion.
Yeah, I see your challenge. There's it's just a comment from the YouTube from Professor Maswime, and it says that about 50% of preeclampsia cases are coming from PhD levels with non-availability of emergency drugs like Maxoff as part of their national drug supply list at these levels of care. So it's just a comment to buttress your point as to what you talked about. All right. So I think there's no other comments or question. So so it's still Jacqueline. Jacqueline says, absolutely, we are really suffering in the facility, wherever. So I did come. So I think that comes to the end. We don't have any other comments, any questions in the chat box. So that means we've come to the end of today's webinar. And thank you. So I just want to thank everyone for joining today. Our discussions have reinforced the 3 delays model continue to undermine maternal and neonatal survival in Africa. This goes to buttress the points that were made on Monday. And the key message is clear. Equity is not a byproduct of better care. It is the strategy. Okay, so every woman who develops preeclampsia in Africa deserves the same chance of survival as a woman anywhere in anywhere else, it's the way. It is not an aspiration, but the standard our health systems must design to achieve. So the call to action is that as we move forward, advancing pre-eclampsia equity in Africa requires a coordinated action across all sectors and borders. Thank you all again for participating in the commitment to advancing maternal mortality and equity in Africa. So the call looks, you can follow us on WhatsApp on 2+233 202 77699, or you go to our website, and then we want to form a community, so you can use the QR code to join. And also, we want feedback from this experience. We want to know your experience from this webinar. And then also, we want to collaborate. How to support us, want us collaboration. So for general inquiries, kindly go to the APN website. It is on the screen, and the WhatsApp is there. So thank you to everybody, first to our speakers, for a wonderful time. Really enjoyed the presentation, very insightful. And then also want to thank the planning committee, Kwewa Labi, Joyce Brown, David, and everybody, the partners, Africa Network and APE Ghana, Julius Medical Center, and au revoir. Thank you. We meet on the next webinar, which is on the Monday, and that will be with patients' lived experience. I think they should also add their partners and the family members, because they also have a story to tell. So whoever is coming on board, I would request that it shouldn't be only patient experience, but the family members also go through the pain with them whilst they are struggling through preeclampsia on the ward or wherever. Until then, have a safe and good night wherever you are, whether it's morning, afternoon, evening. We thank you all. Thank you, dear speakers. Until then, bye. Bye.
And also a very big thank you to our host, Dr. Yevoo. So thank you all for making this possible. It's really, really appreciated.